Okay, good morning, everyone. Welcome to the San Francisco Interfaith Council weekly briefing for faith leaders on the impact of COVID-19 on addiction. Today, the special guest is Dr. Barry Zevin, MD, Medical Director, Street Medicine and Shelter Health, San Francisco Department of Public Health. This event is hosted by the San Francisco Interfaith Council and supported by the Joint Information Center of the San Francisco Emergency Operations Center. A couple of housekeeping items. Audio, video, and chat will be monitored and recorded for record keeping, training, and quality assurance. By default, all participants will be muted and video turned off to minimize distractions. To submit a question or comment, select the chat button at the bottom of your screen and send a message to Q&A. A reminder that anyone who lives and works in San Francisco can get tested. Please go to sf.gov/gettestedsf or simply call 311. And finally, a reminder that restaurants and bars that serve food outside can now open for outdoor dining. And when you're eating out, please wear a face covering when not eating or drinking. No large group tables unless you're members of the same household. And please sit 6 feet from other guests. Once again, welcome to the SFIC weekly briefing for faith leaders on the impact of COVID-19 on addictions. Special guest, Dr. Barry Zevin. And now I will hand it off to Michael Pappas. Thank you.
Thank you so much, Lynn, and thank you to our team at the EOC's Joint Information Center. I'm Michael Pappas, Executive Director of the San Francisco Interfaith Council, and on behalf of the Council, I want to welcome you all to this morning's online briefing for faith leaders. Since the outbreak of the coronavirus pandemic, experts have not been surprised to see upticks in alcohol and substance-related addiction and spikes in regional overdose deaths. Reports of people in recovery having an especially difficult time and relapsing are also on the rise. Compared to a year ago, alcohol sales have increased dramatically. And although the national data is not yet available on drug abuse and treatment, the outlook is concerning. The San Francisco Interfaith Council welcomes San Francisco Department of Public Health, Street Medicine and Shelter Health Medical Director, Dr. Barry Zevin, supported by the department's addiction psychiatry substance use services expert, Dr. David Pading, who will address the coronavirus's impact on addictions in our city as the featured presenters at this morning's online briefing for faith leaders. This program is hosted by the San Francisco Interfaith Council and supported by the Emergency Operations Center's Joint Information Center. And with that, allow me now to welcome the Chairman of the Board of the San Francisco Interfaith Council, Kaushik Roy. Kaushik.
There we go. Good morning, everyone. Thank you, Michael. My name is Kaushik. As Michael mentioned, I'm the chair of the board of the Interfaith Council, and I want to welcome everyone and thank you all for joining us as well. It has really been an honor for the council to be able to have these weekly meetings and bring really substantive conversations and some of the foremost experts on the most relevant topics in our lives right now. I want to extend a special welcome to those of you who may be joining us for the first time. Thank you for being with us. And at the beginning of each Interfaith Council meeting or event, we do read our interfaith statement, which I will do right now. This is an interfaith community. Whatever our individual belief, it can be freely expressed here with no apologies. If we are invited to offer a prayer in this setting, it should be offered according to the tradition with which we identify. If we are invited to speak on a subject from the perspective of our tradition, we are free to do so without fear of offending those who come from another tradition. We come together as people of faith to learn from each other that we might better understand the multiplicity of faith traditions in our city and in our world. Good morning, everybody.
Thank you so very much, Kaushik. As we gather here today, there's also another historic gathering in the city and county of San Francisco, and that is the 2020 International AIDS Conference. I had the extreme privilege of working with the Reverend Anna Rossi, Succenter for Grace Cathedral, in planning the interfaith service that inaugurated this conference. And I just wanted to say, before I introduce her, thank you for this Herculean effort and for bringing a spiritual dimension to this historic conference, which has come to our city. And so without further ado, the Reverend Anna Rossi, Succenter from Grace Cathedral.
Thank you so much, Michael, and thank you to all of you who have gathered here to do this most important work this morning. As we begin, I invite you to enter into this time and space, and if you're comfortable, to close your eyes, to enter into the unseen presence of the divine as you know them, into the unseen presence of our communities, into our bodies, and into our breath. We know that many addictions begin as ways of coping with the trauma of life. And so I invite us to begin by giving thanks for the goodness that we have experienced and the traumas from which we have been protected, as well as those ways that we have endured the traumas that we have suffered, for the caregivers and communities that have helped us, and the tools and resources, practices, and pure grace that hold us in equilibrium. I invite us to call to mind and hold in our hearts our own imbalances, our own sufferings and attachments, those sometime pleasures that become or risk to become our prisons. And to call to mind and hold in our hearts those who suffered traumas earliest in life, who learned from others who had been traumatized to dull the pain and comfort their own suffering in ways that became ultimately harmful, counterproductive. To hold the generations and communities that are most deeply affected by addiction and by the coronavirus. For those with limited access to immigration status, food, shelter, safety, and care. Invite us to give thanks for those who have emerged from patterns of addiction, to be agents of healing and hope in their communities. For counselors and researchers, sponsors and religious leaders, public health officials, and all that have made the way to greater health and wholeness just that much easier. I pray for an end to the root causes of needless suffering, for more compassionate ways of governing and more equity of access to services, for sharing in the common good. And I lay these hopes, dreams, and labors before God, who, in the words of Julian of Norwich, is true rest. Rest for the frequently restless, rest for the easily slighted, rest for the unjustly treated, rest for the inwardly disturbed, rest for the innocently harmed, rest for the physically pained, rest for the harshly betrayed. Draw us close when we are in need, and do not let us forget what we can receive. Amen.
Thank you, very much, Reverend Anna Rossi. This is the 14th in a series of online briefings that the San Francisco Interfaith Council is offering to faith leaders, and each one has addressed a different impact that the coronavirus has had. At the outset of the pandemic, when we found ourselves overnight leaving community and finding ourselves in isolation, there was this phenomena that happened that people were having virtual cocktails online. And as much of a joke as it sounds, for those who are vulnerable to addictions, this really was a very difficult phenomenon. And I was thinking about how throughout our city, those who are vulnerable to addictions have been impacted by the coronavirus. We are very, very fortunate to have with us today the San Francisco Department of Public Health's Medical Director in Street Medicine and Shelter Health, Dr. Barry Zevin, and he is being supported by Dr. David Pading, who is the Addiction Psychiatry Substance Use Service Expert at the San Francisco Department of Public Health, as well as an Associate Clinical Professor of Psychiatry at UCSF Medical Center. We welcome these two experts in this field to shed a light and to help our faith leaders better minister to those in their congregations who are suffering from this, from addictions, and to just help us and support us in our work. So Dr. Zevin and Dr. Pading, the floor is yours.
Thank you very much. Thank you everyone for participating here. I am Barry Zevin. I'm a physician, and I've worked in the Department of Public Health with people experiencing homelessness since 1991 in San Francisco. My background is as a specialist in internal medicine and addiction medicine. And my history has been working in primary care and in consultation, primarily with people experiencing homelessness, and have let the problems of my patients guide what areas I needed to be able to have expertise in. And that has led me to becoming board certified in addiction medicine, and having a lot of practice in that area and being a leader in teaching in that area. Just reflecting on some of the things that have were mentioned already today. When I started very specifically because I was interested in working with the homeless population and working with HIV disease. And in 1991, we were in the heart of the HIV epidemic, did not have effective treatment, and were dealing with a novel and deadly disease that many of us who have been through that experience have been really commenting on how these COVID times are reminiscent of that period of HIV, and how those of us who have been through that see the world a little different and see this a little different than those who are younger or did not have that experience. So I think that's important in introducing myself, because in many ways, that experience in the early 90s of working with dozens, hundreds of people with HIV disease, dying of HIV disease, has shaped how I see the world and who I am. Let me talk a little bit about substances, substance use, and addiction. We think about, in medical terms, substance use disorders. We think about addiction as a disease. But there's a lot of paradigms about how we think about mind and mood altering substances. And I speak primarily from a medical paradigm, and I'll describe that. But I think it's really important to say that within that medical paradigm, there's a lot of different areas. And outside of that medical paradigm, there certainly are dozens of ways that we can think about how and why somebody might use a substance. In terms of the medical paradigm, not everyone who uses a substance has a disorder or a disease. That is very important. We're used to thinking that way in terms of alcohol, a legal substance, perhaps cannabis, a legal substance. But when we think about substances that are criminalized, we may very quickly jump to, well, if this person uses cocaine or heroin or something else, maybe it's because they have a disorder or disease. When use of a substance becomes a disorder, we have formal definitions of that in medical practice. They're outlined in the DSM-5. But there's also, I think, common sense definitions of when use of a substance becomes a problem and perhaps when it becomes something that is in the medical realm of an addiction. I think one of the important things in the medical paradigm, and it's very important when we think about the impact of COVID, is the importance of what we call set and setting in substance use. Sometimes I think this is not surprising to anyone thinking in common sense terms, but can be surprising for those of us who look at this from a professional lens. Where you use, when you use, who you use with has a huge impact on the effect of a substance and on the impact of that substance on a person's life and health. This is something we've really needed to study, and there's some fascinating things that can come out of the study of that. But I think that what's really important here is just starting out with the knowledge that the incredible disruption that COVID-19 has made on all aspects of our lives has changed the effect of set and setting on the substance use that people may be having in their life. I'll come back to that. So when I say a medical paradigm for substance use disorder, what do I mean? We think of substance use disorders as a brain disease. We think of it as a brain disease with physical, mental, social, and spiritual aspects. We think of it as something that is incurable, but treatable. To my medical colleagues, the term incurable sets people on edge. But I think that it's fair to say that addiction disorders at our stage of science are incurable conditions, but not things that are untreatable, not things that we can't help. It's also really important to recognize that substance use disorders, unlike other health conditions, or maybe in a very accentuated way compared to other health conditions, have effects on the whole person, have effects on that person's family and friends, and have effects on society that other kinds of conditions and diseases may not, we don't think of in the same way. And I think in that, it's also important to recognize that one of the most prevalent other paradigms that we think about in terms of substance use is the criminal justice paradigm. We have defined a whole range of substances as illegal and in and of themselves have decided they are harmful to society, and people who use them need to be punished. And that has really far-reaching effects on both the effects of using that substance by a person and on our social structure. So again, something to think about as I'm talking more specifically in terms of the impact. A couple of other background items. People with substance use disorders most often deal with them without medical or other professional help. And most people may have a substance use disorder as we define it professionally at one period of time, and then that is no longer a disorder or problem for them without having sought medical or professional help. And sometimes that may recur. It certainly is a problem that can be helped by interventions in the medical, psychological, social, and spiritual realms, or some combination of interventions throughout those realms. And I think in many ways, both I professionally and the group who's gathered here today, I particularly have an interest in what are those interventions and how do we apply them in a way that is most helpful to the people who have this as a condition. Another part of the medical paradigm, although historically it has not been considered that way, is the need for harm reduction for people who use substances. After all, we are concerned about this because of the harms that it has on the individual, the harms that it has to family and friends and society. And every aspect of how we think about substance use as a problem, we need to think about through the lens of harm reduction. And that means that we actually need to think clearly about what are the harms and what are the causes of the harms when people are having harms from substance use. And I'll add in this context, how does COVID change that? And I'll try and address that momentarily. Just in case people are not familiar with the term harm reduction, or if they are, maybe they have a limited view of this. This is the point where I would be interactive ordinarily when I'm giving this talk, and ask people for ideas about what do we mean by harm reduction and what are some common examples. I'll give a few, and then maybe in the questions there might be some questions about that. But we often think about harm reduction in terms of prevention of the harm of infectious disease. Classically, supplying clean syringes and clean equipment to those people who inject drugs to prevent HIV and hepatitis C. In many ways, needle and syringe access and exchange has been sort of the example of harm reduction that if people know anything, they know that. But there's a whole realm of other harm reduction that we can talk about. Appointing a designated driver back in the days when there were bars opened and there were family gatherings where people might drink alcohol. Very important harm reduction intervention. Thinking about more immediate needs, we've really had to think about how do we do harm reduction in the time of COVID. There are many kinds of substance use where people might be sharing a pipe for something that's smoked. It's kind of a scary scenario in the time of a deadly respiratory virus. And we've needed to really think about how do we provide pipes for people who might use drugs by smoking them. And that's raised quite a number of interesting conversations with organizations that we work with. We need to, I think about barriers as the primary construct as I think about how do we implement harm reduction, how do we implement treatment, how do we get people toward what we might call recovery. And really thinking about what are the barriers to that? And particularly in this time, what new barriers have COVID-19 raised? So that'll be part of how I think about this, and would really encourage people to think as they might be counseling somebody or talking to someone, what are the barriers for this person? What are the gaps perhaps in care that are created by COVID? And particularly in the area of relapse prevention, what are the important barriers that might be new in this era? Almost, so be patient. I'm almost getting to the impact of COVID here, but I felt like I needed to create that structure. Just a few thoughts on the term recovery, because that's something that professionally we talk about in terms of addiction disorders, and a term that is used very widely. And the term comes out of a tradition of Alcoholics Anonymous and other 12-step programs, and in those programs has a very specific meaning, very much related to abstinence from substances, abstinence from all mind and mood-altering substances. And the term recovery is used professionally in the area of behavioral health, in terms of often termed wellness and recovery, and has a much broader definition in terms of health. And then the term recovery obviously has a lot of meanings and implications in common usage. One gets an illness and recovers from it is a common usage that may or may not have utility when we think about what an addiction is. So I think that bears some thought. All right, the impact of COVID-19. I think some of these words might resonate with people. Stress, isolation, anxiety, a sense of no escape or ability to escape. In my notes, I put the term disruption in all caps. We have seen disruption in virtually everything that we do. And that has certainly impacts here. Decrease in treatment availability, decrease in many resources. Bars are closed. Other social settings where people might use substances together are not available or closed. People are experiencing multiple losses and traumas. Even if they're not sick themselves, they might know somebody who's sick, and all of the regular kind of traumas in people's lives are magnified. And I think for many people, despair has been a big part of the process, whether from job loss or loss of other kinds of opportunities, or just seeing a disaster like this lays bare all of the problems that we had before the disaster started. A lot of what would have been done in person, including medical visits, counseling, 12-step meetings, are being replaced by virtual visits. This conference, doing it by Zoom. It's a very big change from in person. It's been very interesting to hear a lot of enthusiasm for this. And I think for many of us in the field of addiction treatment, we have truly believed that the face-to-face contact, the human contact, is an absolute essential part of any treatment that we offer. And it's been really interesting to try to understand how right was that, or were we overestimating the importance of the actual direct human-to-human contact, or can we replace that with the virtual contact? So certainly there have been reports of heavier use. There have been reports and knowledge that people who would not have used substances alone are using alone. There have been reports of increase in relapse for people who were abstaining from substances or considering themselves in recovery in the 12-step sense of that. And there has been a decrease in harm reduction opportunities. In the population that I work with, people experiencing homelessness in San Francisco, we've seen a doubling or tripling of homeless deaths since the onset of shelter in place. In regular times, we were seeing 3 or 4 homeless deaths a week, which is, of course, way too many. At this time, we are seeing 8 to 10 homeless deaths a week. And that's been persistent since mid-March. And we've been tracking homeless deaths in San Francisco now pretty closely since 2016. And this is the first time we've seen anything like this. Now, homeless deaths have been primarily related to substance overdose and other factors related to addiction for a number of years. And we believe that the current increase is related to overdose and addiction-related causes. That is really sad for me, because many of these are my patients. Scary, frustrating, and it is a huge impact. Whether this is more broadly happening and whether overdose and overdose deaths are increased across all segments of society, it seems to be the case that yes, that is true, especially in the past couple of years as we've had fentanyl and other ultra-potent opioids as a predominant drug in San Francisco. We've seen a steady increase and now a higher rate of increase in deaths. We have seen an incredible disruption and decrease in resources for people experiencing homelessness. Intake to shelters have been closed. Shelters themselves have been closed. People have been moved from place to place. Drop-in centers have been closed. Clinics have been closed or greatly curtailed. There is just an incredible amount of change and disruption. Simply in how people obtain alcohol and drugs has changed. As I said, bars are closed, but the people who are dealing in illicit drugs are very much equally disrupted. And we know historically and now any disruption in the drug supply leads to harm. One of the harm reduction messages that we always give our patients is buy from the same dealer, use the same source of drugs. That way you're not going to be surprised by an increased potency or a decreased potency or some other kind of problem. Well, everything is disrupted and people are not able to buy from the same dealer. And the dealers are not able to buy from the same suppliers right up and down the supply chain like any other supply chain. And this is part of why we've seen the increase in deaths. Sadly, we continue to have criminalization of homelessness. At the same time that we are seeing a huge outcry for social justice and civil rights related to Black Lives Matter. And the mayor really being a leader in this. We see in San Francisco a continued emphasis on the visible homeless not being acceptable. Now, there are many reasons for that, some of them health related, but the response has still been largely a police department response. We do not have housing for anywhere near the number of homeless people. We, therefore, when we say we need to see homeless people off the street, we almost immediately must move toward a criminalization and criminal justice response. We have seen now approximately 2,000 people experiencing homelessness placed in shelter-in-place hotel rooms. Tourism is absent. The hotel rooms are available, and people are in those hotel rooms. And I think overall that's a good thing, although it's scary because, again, putting people who may use substances alone, isolated in a room, is a possible source of harm. Are there any silver linings to this? We can say that for some people, the availability of telehealth, Alcoholics Anonymous and other 12-step, other kinds of virtual connection has really been positive for some people with addiction disorders. One of the hallmarks of the disease of addiction is that people's social networks become severely pared down. Having the availability of a different kind of connection that doesn't involve needing to be face-to-face with your family, needing to actually get up and go somewhere to do something, has actually proven beneficial to some people. And I think it's a lesson that we'll want to continue as we move, hopefully, out of isolation and sheltering in place. Another silver lining I have seen is an increased opportunity for meaningful work for some people. For example, getting people to be the staff of a shelter-in-place hotel or of a organized, safer sleeping area and encampment. That's not a job that everyone is jumping on the bandwagon to have. And organizations that employ people who were previously involved in the criminal justice system, like Urban Alchemy, that hire people who perhaps are on probation or parole, or who are getting out of prison or jails, has given an opportunity for people to have work that's meaningful. And when I talk about the spiritual aspects of addiction with my colleagues who get very nervous when I say biopsychosocial spiritual, they surely understand the biological, kind of understand the psychological and social, and kind of get the willies when I start to talk about spiritual as equally important in this. What I'm talking about is the meaning in people's lives and the kind of existential aspect of needing meaning in your life that's lost when you have an addiction disorder and needs to be there. Certainly that's lessons from 12-step, but that's also lessons from what do we see in terms of how people live their lives and what's lost and what can be helpful. So I think there is that increased opportunity. we're also seeing some rationalization of laws and regulations regarding treatment. And the availability of medications, particularly buprenorphine and methadone, to individuals with opioid disorders, which we know are our most effective medical pharmacological interventions, but have been very limited by, in many ways, irrational laws and regulation. That has needed to change, and maybe we'll see some permanent changes related to that from this disaster. So what's helpful? What can we do? And then I will leave it over to perhaps Dr. Pading has a few words, and then others will have questions. The sense that people need connection and are looking for connection, absolutely true. The sense that this disruption has changed how people are relating to their drug of choice, as I said, set and setting is important. We talk about a person's relationship with alcohol or cigarettes or other drugs, and how that relates to their relationship with other people. And we need to at least be talking about that and encouraging people to talk about that in their families, in their social settings. How has your relationship to alcohol changed in this time? And a lot of people I've been talking to have said, wow, I didn't realize it, but that cocktail I have after work, when I come home from work, now that I'm home all the time, has turned into something very different. And really talking about, well, what is that relationship, and perhaps what is the meaning of that drink or that use of cannabis or that use of another drug? So I think it's very helpful for all of us in our families and in our relationships and in our roles to be talking about that part of it. Recognition that there's some opportunities in here, as well as all of the risk and disruption, I think has been very helpful to me to get through. I'll leave off there and see if David has any thoughts, and then the questions from our panelists.
Good morning, everyone. I'm David Pading. I'm an addiction psychiatrist and mostly manage policy and services for the city and county of San Francisco. I've worked with Dr. Zevin for a long time as colleagues and friends, and Barry has always been the go-to person for what's happening on the street. Barry, I'm just going to make a comment and ask you to maybe respond to this as you're talking. You know, I'm always reminded that persons who are experiencing homeless, while people may feel they're different from those that are housed or in our congregations, there's many of the same needs, so different but the same, that the community of drug users and community of persons needing that are homeless have the same needs as ours. And as I'm hearing you talking, I'm thinking again of the impact of isolation and distancing on the homeless and how it's disruptive to their community and the impact of their using. So my question is, you know, when you're walking the streets, and I know you're out in the clinics doing field work, what's been your sense of that, the sense of the community among persons that are homeless? I think you've talked about some of the impact on the downstream end of the drug use, but you know, what's it been like when you're actually talking to folks? What are they complaining about? What are they worried about? And if you could just paint some of that street side view.
Sure.
Because I think it's a good mirror on what we're experiencing as well.
Yeah. Well, I think that's really important. When I first started giving talks earlier in my career, I used to say, homeless people are isolated. And as I learned, that was completely wrong. It's very rare for me to run across somebody who's actually isolated. It's that image of the hermit who lives in the woods is a real rarity. people need other people. They're in communities. They might not always be healthy communities, but it is an absolute necessity to life. So that's a really important perception, David. As we're talking to people, there's a few common themes that are coming out. One is a sense of being abandoned. People feel like they were not cared for before, and people feel like, especially in the first month or 6 weeks, almost all of the outreach teams that were on the streets were no longer there. People were no longer there. And we heard over and over from people how this sense of abandonment. I'm just out here. There's nothing opened. There's nothing for us. And I think we've started to address that somewhat, but we're still hearing it to some extent. We've certainly heard a common theme of, in some cases, frankly, paranoid, and in some cases, on the borderline of that, of this COVID-19 is somehow a plot against poor people, against people of color, against people experiencing homelessness. It's a scam. It's a way to harm us. And again, people who've been severely traumatized have extreme losses in their lives. And this is another one on top of that. It's not surprising that we would see that kind of attitude. And people need that human contact to understand what we're talking about. I think we've also gone out, I talked about the criminalization, and we've gone out on the street and given people the wrong message. We had a very strong message that got transmitted to the police early on, that spacing tents 6 feet apart was the most important possible thing we could be doing to prevent the spread of COVID among people experiencing homelessness. And that again absolutely led to people feeling battered, feeling like we have a community here, and we're in a tent, for God's sakes. This is better than being unsheltered, and yet we're being told that tents are wrong, and having the tents together is a danger. Was pretty disruptive. So I think that we have really needed to go and get the message that yes, physical distancing and social distancing and mask wearing is really effective and important. And we need to do that in a way that doesn't disrupt people's community and give them that message, because there is quite a lot of despair out there. And honestly, I think that is very much driving increased drug use and driving increased overdose death. And I think David's point is right, that is also reflected on the broader society.
Dr. Zevin, thank you so very much. This presentation has been so comprehensive, and you've raised issues that have given us all food for thought. Dr. Pating, thank you for that question, and I hope that you will remain with us, because we have 3 panelists with us today who are sort of boots on the ground and are doing this work in different sectors of the faith community. I'd first like to introduce Kevin Fateau, Director of Catholic Charities, the Derek Silva Community. Kevin, would you share with us a little bit about your work and then ask a question of our featured presenters?
Sure. Good morning. I'm the director at Derek Silva Community. It's a Catholic Charities program. We have about 68 low-income clients living here. It's residential. All of them have a physical health condition, and many of them have what's called a triple diagnosis, which besides the physical health, they also have mental health and substance use issues. Sadly, we had a death yesterday, and we've had 2 other deaths in the past couple of months. What that has created here is a deep anxiety, because of course, in the time of COVID, the 68 people living here are assuming, they're thinking that the deaths were COVID related. And that makes them scared, of course, because now they're thinking, wow, am I next? Am I going to get COVID here in my home where I'm living in this program? So they're very anxious about that. So the first thing we do is reassure them that we've provided every safety measure that we know of here in the building. So we have everyone wearing masks. We don't let in outside guests unless they're health professionals. There's no congregating. Everyone has their own room, their own kitchen. So we assure them that they're very, very safe as much as possible. The problem is that as much as that works for most of the residents, the ones it doesn't work for are people with substance use issues. People who have addictions are not as concerned about the future, and they're more concerned about the moment. So someone here who has an addiction issue is not anxious because of the COVID, because of thinking, oh, I'm going to get COVID and I'm going to die. They're instead anxious because, hey, if I get COVID, I'm going to be stuck in my room. I can't get out, and I'm not going to be able to secure what I need, which is drugs or alcohol. So they're very anxious about that. They're anxious that if I get sick with COVID and I have to go to the hospital, I'll never be able to get out of the hospital. No one can visit me in the hospital. So they're anxious again about the immediacy of the effect on them in terms of their substance use issues. So for those people, we have to address the anxiety in a different way, which is what we do. We contact everyone here every day to check in on their health. With people with substance use issues, we more intensely work with them. It's very important first to make them feel that we're there for them. As was mentioned earlier, there's a sense of abandonment. There's a sense of isolation in their rooms because of shelter in place. We meet with them every day. We'll talk on the phone. We deliver meals. We keep distance, but we meet with these clients and we assure them that we're there for them. We try our best to help them realize, hey, we're here, we're listening, and the most important thing, talking about harm reduction, is we're not judgmental. They know we accept them for who they are. So we let them know we're here. How can we help you? How can we deal with your anxiety? This allows them to feel that they're not being judged for this substance use, and instead that they can open up. They can share how anxious they are about, in fact, their substance use issues. They're anxious to get outside. They're anxious to get what they need. Here, for most of our clients, substance use comes out of what's called self-medication. Many of them have trauma, deep traumas in their backgrounds. And they find that in substance use, they find a relief from that trauma. Someone who's terribly depressed finds that taking speed, methamphetamine, gives them the energy that they don't have when they're depressed. Someone who's suicidal finds that taking opiates, taking heroin, man, it creates this euphoria that they don't have, and which then gets rid of their suicidal ideation. So substance use for them is a way of medicating themselves, of getting rid of the anxiety. So we work with them. We let them know we're not judgmental. We let them know that we're here to help them in that anxiety, and particularly the anxiety about COVID. I use, and since we're talking here with the faith community, I use as an example a biblical reference that everyone knows about the adulterous woman who's going to be stoned. Jesus comes into the picture and he says, hey, let the first person there without sin cast a stone. And no one does. They all leave. And he says to her, hey, no one has judged you. I don't judge you. Go and sin no more. My take on that is he doesn't say to her, go and sin no more, and then we won't judge you. First, he says, we don't judge you. We accept you. We love you. We care for you. Based on that feeling of being loved and cared for and not judged, hopefully then she feels the courage, the inspiration, the sense of support that maybe now she can go and sin no more. So that's our approach here, is basically the harm reduction approach. It's not abstinence. It's we accept you for who you are. We're not judging you. And when they know they're not being judged, when they know that they're being accepted for who they are, they will open up. And then hopefully we can find alternatives. We can say, go and sin no more, in the sense that, hey, here's some alternative to your feeling anxious. Here's another way of dealing with that anxiety. When you're feeling stressed and you need to go out and muse, because anxiety is a trigger. Anxiety brings up the feelings of, oh yeah, I know how to deal with this anxiety. I'm gonna go out and use. When instead we're there and listening to them and we say, hey, you can call me anytime. I'm here for you. You know that. Hopefully that will be an alternative to go and sin. That'll be an alternative to, not that that's a sin what they're doing, but in terms of the biblical reference, that you don't have to go out and use. We're here for you. And that's, I think, the major difference that we make here in working with our clients, is that harm reduction approach. And that's pretty much what we do. So my question then for Dr. Zevin, in spite of all that we do with that harm reduction, in spite of working with people and letting them know we're here to help them, we do have non-compliant clients, the ones who just don't care. And they go out every day. They go into the community. They're actively securing their drugs. They go out without masks. We see them outside. We see them hanging out with the drug community. We see them congregating. So we know that they're in the midst of the possibility of COVID. And then they come back in the building, of course, and this is in and out all day long. Now, the building cannot prevent them from coming back or leaving the building, even though it's shelter in place. There's no law that says you cannot go out. So one, it affects them, of course, because they could be being exposed to COVID, which is very likely. And two, even to some extent worse, is that when they come back in the building, the other residents see that, they experience that, and that makes them frightened to see several people who are out all day in the drug community coming back into the building, going back out, coming back in. That scares them, and that ups the anxiety in the building. They demand from us something has to be done about that. Why are these people being allowed to come in and out when we know that they are potentially and dangerously bringing in COVID with them? So that's our challenge, is dealing with that. Now, of course, we deal with it in harm reduction. We work with these people. We say, hey, come on, when you're in the building, you have to wear a mask. You really should wear a mask when you're outside. We tried all those approaches, but it doesn't reduce the anxiety in the building of the fear of these people coming back in and exposing other people in the building. So my question for Dr. Zevin is, do you have a thought on, and it's a really impossible question. So we don't have a good answer. DPH doesn't have a good answer when we talk to them about the potential of being exposed to COVID. But we need to do something more, and I don't know what that more is. So maybe you have an insight, you have a thought into what that more might be.
Thanks for the impossible question, and thanks for what you do at Derek Silva. I think that like many of these things, it's absolutely mostly a one-on-one long-term conversation. Can we change what's motivating that person, and use their own motivation in ways that will help the community. I think the other piece of it is there are probably some policy pieces that we need to think about in terms of what is driving that. Where is that person going? Why are they going and hanging out all day? Is there something else that they could be doing? Certainly, we've heard a lot in the harm reduction world about safer injecting sites, safer consumption sites for drugs. And if people are going out and using all day somewhere in the community, would there be a safer place for them? This may or may not be the moment to revive that discussion. And there may be many other kinds of out-of-the-box thinking. But I think it is a problem. I'll just mention one other quick thing. That sense in your building and dozens, hundreds of other buildings that we're not having guests and we're not having overnight guests. And then a huge amount of hand-wringing about why do we see so many people on the streets? Many, many people experiencing homelessness on any given night before COVID, estimate of over 1,000 in the Tenderloin alone, would have been spending the night with somebody who actually had a home. I'll stop there.
Thank you, Doctor. Now we'd like to turn to the San Francisco Police Department of Community Chaplaincy, Community Chaplain Coordinator, the Reverend Dr. Megan Rohr. Megan, would you give us your perspective and your work in this arena?
Absolutely. Some of the things that we do kind of during this time frame is we have kind of two parts to our chaplain component through the police department. One is care directly for first responders through police chaplains, and then care for the community, which is chaplains who are trained to be called out by the 911 system, by the emergency response system, to be able to support people who are grieving through a death or through a loss or through some sort of big traumatic incident where having faithful people of all varieties coming out to support community members can be a helpful thing. On the community side, what this means is something that I want to kind of maybe think is the piece that I can lift into this conversation, and that's just to talk really frankly about suicide. And it kind of goes hand in hand with addiction issues. We talk about a triangle, a suicide triangle, people who are depressed, people who have access to a firearm, and people who also have alcohol in their system. And so that's first responders fit very clearly into that. They're people who we know experience a lot of trauma, and oftentimes they're people who carry firearms. So if you add alcohol into that equation, it can be really difficult. I've seen more times that I'm being called to support families after a suicide during the shelter-in-place time. I think part of the dynamic is that people have less access to some of the mental health care support, as Dr. Zevin was talking about. I think another part of it is that some people are afraid when their depression might get to a level that they might normally have gone to a hospital. I think people are afraid that they might be exposing themselves if they see some other treatment options out there. And if people have fewer members of their community who are checking in on them, there might be fewer people to suggest that people get help. And so I think it's a combination of everyone going through an emergency simultaneously. Like, this is very rare in our human history that we're all exposed to the same trauma at the same time. Traditionally, the way pastors care for people, ethically, the way therapists care for people, is that people who are outside of the emergency tend to come and help people who are inside of the emergency. And during this time of the coronavirus, we're all inside of this emergency. And so we're all kind of experiencing the ways that our chemical balances change with our adrenaline and our cortisol. We're all experiencing a change in what we see in the world. Police officers often tell me that they have a hard time right now because they used to be able to, throughout their day, check in with community members who were really positive experiences. You could go talk to the business owner, you could go talk to the people who are walking their dog, you could have these friendly interactions that help to fill in the spaces in between when something hard happened, when something traumatic happened. And now, in a time when a lot of businesses are closed, people are less feeling like they can talk to each other freely and openly. You might have just more of the tough experiences, no positive in between, tough experience, no positive in between. Our news is like that, kind of 24/7. If you have protesting, right, that's kind of ramping up also these feelings that everything is broken, everything is hard, which I think adds to all of these issues for folk. First responders, because given the number of faithful folk that we have who watch these calls, I'm sure there are many who are parts of our faith communities, are 30% more likely to have an alcohol or substance abuse issue. Here in San Francisco and throughout the world, first responders are more likely to die from alcohol addiction issues or suicide than they are from in the line of duty deaths that we might imagine from their jobs. Part of that is because they live in critical incidents like this. And so if in your own body, you've noticed you have a little bit more acid reflux than you used to, you might space out more often than you used to, you might have trouble sleeping fully through the whole night like you used to, you're getting a tiny taste of what first responders live with in their body all the time. And as those ways that our body changes happens, you might have also noticed that a lot of those changes happen in our gastrointestinal tract, right? Trying to stay regular in the middle of an emergency, like bubbly waters and good fiber can be really important. But think about how this also affects addiction and substance abuse. If the organs that help our body filter out these chemicals are already overloaded with our adrenaline and with our stress, then our relationship to an addictive substance might shift just because other chemicals in our body have shifted in a major way. And so I invite people, if they're noticing this in themselves or in other people, if you might be a tough caregiver, like a first responder, maybe talking about someone having an addiction issue isn't a place where you can go because you know you're a professional and you got a hold of yourself. The way that we talk about this with first responders is just to simply say, if you have a problem that you can link to your drinking or to an addiction issue, then you have an alcohol problem, right? That problem is the problem. It doesn't mean you have a diagnosis of anything, but that you have a problem that you can ask for help with. I also want to lift up that right now, because so many of us are sheltering in place. I happen to be in my living room where we do worship, but it's a lot easier to disappear for a little bit of time and not have people necessarily notice that you're gone. You're not in a workspace with all of your colleagues. So it might be one of the easiest times and the most stigma-free times for people to consider some sort of recovery center, especially if it's an inpatient recovery center. And I think if one of the big barriers that people have is kind of this fear of asking for help, that this might be an easier time to ask for help than other moments that we might have. The other thing that I wanted to lift up is that there is, for me, a really critical reason that I'm involved in chaplaincy work with first responders, and that's because I have a family member whom I was with at a Christmas celebration or some sort of holiday celebration, and we were all at my grandmother's house. She has like 11 beds, so almost everyone gets to sleep in one. I had been given the couch because that's just where I happened to rank that particular holiday. And one of my relatives, who was an EMT with the fire department, was driving me crazy because they would stay up late in the dining room and drink, and they wouldn't go to bed. And the longer I was near them, the longer they would talk. That's kind of what happens to faith leaders. And what I discovered is that they were thinking that everyone was going to go to sleep and that they were going to continue drinking to try to solve the fact that it was very hard for them to fall asleep during the natural rhythms. But it put into my heart this idea that we need to care for people whose jobs are injuring them, right? So people whose jobs it is to run towards trauma and care for people need our care in a very special way. And that means sometimes staying up and listening to folk and helping people get the support that they need. And my hope is that people can get some of that support earlier in their career rather than later in their career, so it does a little bit less damage. Thankfully, there are some new resources that the city has. If you know some first responders, there are new phone apps made by Cortico that have all the mental health care information you need on them that firefighters have, that the police officers have, that the Department of Emergency Management all have access to now. And that even has a whole grouping of self-assessment tests where people can check if they have an addiction issue or need some support in that area. So that's a couple of resources that people can take on for themselves. I also wanted to name, as a member of the LGBTQ community, that there are some ways that maybe our addiction use has gone down. Our Pride celebrations were mostly virtual. There was some marching that happened, but traditionally there is a large component of that celebration that is making so much money and donations for different community groups through selling beer and just through selling alcohol. So some of our cultural events have decreased the amount of substance that we have used, and perhaps we have untangled some of our rituals from those rhythms of feeling like drinking is the Pride celebration. And so I think that could be a really lovely thing. I wanted to offer up a question for Dr. Zevin. One of the things that is really hard for first responders, and I think for me while I shelter in place in COVID, is that it becomes more difficult to try to feel pleasure to have dopamine responses in our body when we're in the middle of trauma. And long-term use of addiction also mimics some of that same way of decreasing our ability to have pleasure and to feel like anything other than drugs or alcohol can provide pleasure for us. And I was wondering if you knew any recommendations about ways that people could experience hope and experience joy, whether they have a long-term addiction issue or they're just feeling depressed in times like this.
Thanks. My usual go-to answer for this, in many ways, is still available, because we know for depression and for not being depressed that exercise and exposure outdoors is needed. And I think one of the things that has been good about the health orders and the shelter in place is that we have said going outside, doing exercise outside is acceptable. And I think that's really a critical piece of this is aerobic exercise outdoors. And that's been a lot, it's been really hard because going to the gym has been very much in a lot of people's way of being in this world, and gyms are closed. And that doesn't mean that we can't encourage people to do walking or other aerobic exercise outdoors in a safe way. So that's one piece of it that has a bunch of very strong clinical evidence for this. And I just will say, we often throw up our hands for people who use methamphetamine because it can be very challenging to treat. Aerobic exercise has been one of the very few things that's evidence-based for that.
Dr. Zevin, thank you for that permission. I'm going to go out and exercise this afternoon when we're done here. Our final panelist is the Reverend Paul Trudeau, a friend and colleague and the co-director of City Hope San Francisco. Paul has also done some important work in chaplaincy in our jails as well. Paul, would you talk to us a little bit about your work and then pose the final question to Dr. Zevin?
Sure. City Hope is located in the west corner of the Tenderloin, and we really consider our center a living room for those that don't have enough living space. So we serve the needs of a lot of people that are on our streets in a shelter or in the SRO kind of living spaces that don't have very many living room spaces. So in normalcy, we would gather people and create really great dinner parties, really restaurant style meals, giving people the dignity of that meal, as well as dignity of choice in what they eat, while enjoying bingo or karaoke or a large screen, movie theater experience. And that's our joy. That's us doing what we love to do. We've been open for 5 years, and for 5 years, I've told people that we don't do takeout and we don't do fast food. Our goal is to slow people down, to know them, and to create that non-judgmental space that builds healthy community, especially for those who are struggling with addiction. That is just like a very vital, healthy choice for them to do, is to join us. Since COVID, we're only doing fast food. We're only doing takeout. So all the food has gone out the door, and that's been a challenge. We've tried to maintain our priority of saying everybody's name multiple times when they come in that line. That's our metrics, even more than the meals that we serve, it's the names that we say. And so we have a consistent community coming for their provisions, not only meals, but toiletries and masks. The challenge I've been dealing with is, social distancing in the Tenderloin is very challenging. Having people respect the space while they wait in line. I've never wanted to do a food line, but here we are. and spacing someone gives the opportunity for another person to jump the line, you know. So that's some of the struggles that we see, but we are serving more food than we ever have. And not only hot meals, but we partner with the food bank and do grocery deliveries to the SROs. And that's another human contact moment to show people that they matter, that we see their needs, and we're here to help in any way we can. I'd say one of the tough things is we're doing more with less. We're not trying to crowd our room with volunteers, and the community is part of the solution. So they are our volunteers, and they want to be in that space, not only to partake in what we do for them, but also with them. And we just can't do that as much as we were able to do before COVID. So that's one part of City Hope. The other part of City Hope is the City Hope House. We house 25 men and women in a 2-year sober living environment. And we take the graduates from a 1-year program. Once they graduate, when they have that diploma from these wonderful places throughout our city that are helping them get to year 1 and give them 2 more years. And these typically, or give them 2 years of affordable living in a sober environment with a lot of great community support. So it isn't harm reduction, it is sober living environment. And we typically are getting people that are choosing, a very sober lifestyle and are very active in the recovery community, are essential workers at our grocery stores, are delivering the packages, just amazing people. And we house people that are the drug and alcohol counselors at other facilities now. And so we feel like that is our place. That is part of our calling, especially in the ways that we can help people develop and take that next level into their sobriety. And what we're seeing in COVID is we've seen a couple more relapses because of the stress, specifically those working at grocery stores. The first couple I guess weeks or months was so incredibly stressful for everyone, and yet the grocery stores and everybody's desperate and hoarding toilet paper. These were the people that were dealing with that, and of course their addictions were being triggered at that time. But we've been able to stabilize the house. I really feel like we've gone from sprint to marathon now with COVID, and it's a lot of just that. The spiritual community is so important, I think, just for that encouragement, that love, that care that we provide for people in their lives, of knocking on their doors. We started a cookie campaign where all these churches gave us cookies. And so we just give out homemade cookies. It was one thing that we could do that was safe and just an expression of care and love to both our friends on the street, but also the residents in the City Hope House. So that's kind of what life has been looking like for us lately. I think my question for you, Doctor, I could listen to you all day long, by the way. This is really great. I loved what you said about how, the bio-psychological and spiritual all need to be kind of firing on all cylinders for our health. And we certainly understand that. We, the faith community, speaking for us as the faith community, we come from the spiritual side. And I'm curious, people we do have a long line. We're feeding people, and I'm trying to do pastoral care for people. And I do feel, people might not be dying from COVID, but they are dying from their addictions, and people are passing away. And they're leaning on us as the faith community in those moments for prayer and for care. But I also want to be able to offer that biological information that is so vital to keep my friends alive. And I resonated with something else you said in regards to, like, there's a lot of misinformation out there. You said borderline paranoia. Or someone said that, maybe it was you, Kevin. But how do we inform these people that depend on us spiritually with good medical advice on COVID? Is there resources for that? Because as I surveyed the line this past week and just asked people what it was like for them in COVID, you know, some people were like, this sucks, I'm isolated. Some people were, you know, people are coughing on me and it's driving me crazy. Why aren't they giving me my space? And then, but over and over again, I heard people who live on the streets say, I don't think it's even real. And I specifically remember, you know, back when this first started, somebody jumped in the line, pronounced to everyone, hey, the president said it's going to be over by Easter. And I was aghast. Like, how do I, as a spiritual advisor and minister who they trust spiritually, give them good medical advice on COVID? So that's the question.
Thanks. That's a great question. I think there was there's great information out there, and yet I don't think anybody much has developed great information that's culturally appropriate and speaking to that portion of the people who are saying, I don't believe it's even real, and that portion of the people who are saying, yeah, it's real, they made it in a lab to kill Black people. Yeah, it's real, they made it in a lab to kill homeless people. I don't think that anybody quite has that yet. The National Healthcare for the Homeless Council has a website that is often cutting edge on this messaging, so I'd keep an eye on that. I think that if I had a good answer to it, we would have developed that flyer already. But I think it's really hard and goes back to histories of oppression, histories of there's reasons why people have attitudes that can sound crazy. I think that the one-on-one discussions, the one-on-one, how is this affecting you? Why are you thinking that? What is that about? Can be very helpful in changing people's minds. When people do not feel cared for, this is when those misinformation absolutely explodes. When people feel cared for, they are a lot more able, even when we are talking about somebody who might have a severe mental health disorder, they're able to discern who is trustworthy. But if no one ever is trustworthy talking to them and giving them the message that I care for you, then I think we're really can be in trouble. So I think the best thing we can do is make sure we've got the right information, and there's great information from the Department of Public Health, and that we're the ones who are translating it to the people who might not have access to that information, or if they do, they're not having access to that information from somebody who they actually felt like they could trust. So I guess that's an answer to that. It's very frustrating to me, and I don't think we've made a lot of progress in our outreach all the time.
Dr. Zevin, we can't thank you enough, and Dr. Pating as well. Kevin and Megan and Paul, you all raised issues, and I'm going to echo what Paul said. We could sit and listen to you all day, Doctor. I did want to let you know that since the outset of the pandemic, when the community branch was activated through the Department of Emergency Management, it's been the San Francisco Interfaith Council that's been conveying all of the official notifications, aggressive recommendations, and public health orders and getting those clarifications. It's the unique role that we've been designated to play. We are at the close of our time, and I just wanted to say thank you to all of our participants today, as well as to Cynthia Zambucas, the Program Associate and Administrative Associate of the San Francisco Interfaith Council, as well as to our team at the Emergency Operations Center, Joint Information Center, beginning with our coordinator, John McKnight, as well as Sharon Walton, Trey Russell Allen, Lynn Mays, and Hafiza Salebai for their incredible work in facilitating this conversation. And I want to extend an invitation to everybody to join us next week. We will be discussing the impact of the coronavirus on the 2020 census. A reminder that today's recording will be sent out to our 5,000 e-subscribers, and any questions that you might have submitted, we will forward to Drs. Evan and Dr. Pading, and as they're able to, they'll respond. Thank you all, and this concludes our program for the day. God bless you and God keep you.
Thank you.